Physiology. What comprises your whole blood? Well, it's about 55% plasma. Mainly in the plasma, you have proteins and water. Of course, the most abundant protein is going to be albumin. In your formed elements, which is about 45% of your whole blood, you have your thrombocytes or your platelets, your leukocytes. So that includes your granulocytes, such as neutrophils, eosinophils, and basophils, and of course your lymphocytes. And you have your erythrocytes, which are your red blood cells. Lifespan of erythrocyte is about 120 days. Platelets do last about 8 to 10 days, and of course white blood cells usually only live for a few days. Cells do travel to the spleen to die, and they are filtered there, so the spleen is an important organ for the patient. So how are red cells produced? Well, if you remember that your erythrocytes live in the bone marrow as proerythroblasts, and under the control of the hormone erythropoietin, they are going to fully differentiate into erythrocytes. So if you recall, there is usually a stimulus for the release of erythropoietin from the kidney that's usually a low flow state or a low oxygen state that's going into the kidney. The kidney senses that because it's very sensitive. It immediately releases erythropoietin. Erythropoietin goes right back into the bloodstream and travels to the bone marrow, and it controls, it signals the bone marrow to go ahead and release erythrocytes into the body. Body, believe it or not, makes about 2 million erythrocytes per second, so it can always keep up with the natural destruction of them. And if you are in a time of hypoxia, the bone marrow will increase that rate to about 17 million per second. Do recall that the hemoglobin is the oxygen-carrying protein of the erythrocyte. There is usually 2 globins and 4 heme. The heme is the flat part of the disc that carries a molecule of oxygen. So when you think about a hemoglobin, you have 4 molecules of oxygen. And when each hemoglobin, with each heme is saturated with oxygen or carrying oxygen, then your hemoglobin is said to be fully saturated. And that's really where your O2 sat comes from. Going back, you also need vitamin B12 and folate for erythropoiesis. Folate is needed certainly to make the DNA and RNA within the cell. When you think about hemostasis, you think about usually that's a combination of clotting factors and your platelets, right, your thrombocytes. So in order to have effective hemostasis, you do need both of those things. Platelets are matured in the bone marrow. They are, of course, under the direction of the hormone thrombopoietin made in the liver. Platelets do circulate for about 8 to 10 days. They usually circulate in their inactivated form, and they are usually waiting for something to do or something to activate them in order for them to become sticky. Or form a clot. So when there's damage to a vessel, for example, hemostasis occurs after there's vasoconstriction at the site to stop the bleeding. If you remember, you have the inflammatory response to help us with that. You have activation of the platelets to form a plug. You then have activation of the clotting cascade to stabilize that plug. And then you have fibrinolysis, which occurs to degrade the oversized plug and essentially clean up the mess. Blood clot is what stabilizes the platelet plug. You have strands of fibrin produced by the clotting cascade through both the intrinsic, which is inside the vessel, or the extrinsic, which is outside the vessel through the wall, pathways. So if you remember the intrinsic or extrinsic pathways, they both of those pathways, no matter which way they're activated, converge on factor X, and that's what ends in the formation of the blood clot. So you have this blood clot, which is, of course, at the end of the clotting cascade, which is the final product of the clotting cascade, the full clotting cascade. And so you have this release of clotting factors at the sort of injury site, both from the cells at the site and also the platelets that have been activated, and that does form the temporary platelet plug. You then have chemical reactions, which is really what the clotting cascade is all about, and that creates thrombin, which stabilizes the plug. And then you have this fibrin mesh network that essentially traps red blood cells that are driving on by through the bloodstream to actually form that clot. But if you recall, that clot is kind of a messy product. Even though it's necessary, it's still kind of a messy thing. So the body does this amazing thing that called fibrinolysis. So it basically, once this fibrin clot is made and those fibrin threads close together to stabilize it, there is a plasma protein released basically from the liver called plasminogen. This plasminogen is then converted to plasmin with the help of what's called TPA, which is tissue plasminogen activator, that's expressed from endothelial cells that's found basically in the tissues themselves. And that essentially just degrades the fibrin in the clot. And that creates something called fibrin degradation products. Most notable for nurses is what's called the D-dimer. Your D-dimer really should be very low, usually less than 200. And so when that D-dimer is elevated, you know that you've had clot formation, and this is one of the tests that's really important when we look for DVT or PE. It doesn't really tell us where the clot is, but it does tell us that there has been a clot that has recently been degraded. So it can be a very important blood test that you might find done in many of your patients. So when you have damage to the vessel wall, if you recall, platelets get activated by thromboxane. That starts them working. So platelets usually arrive at the scene of any kind of vessel damage first. And so if you recall, going back to your pharmacology, this is platelets produce something called cyclooxygenase, which converts to thromboxane. So this is why aspirin makes platelets, this is where aspirin works. Aspirin stops this conversion, so aspirin makes platelets less sticky because it basically stops the conversion of the cyclooxygenase pathway. So in the subendothelium, there are fibrinogen receptors such as your GP2B and 2 and 3A in the subendothelium, and so activated platelets adhere to these receptors like glue, and these proteins make the platelet more stable with the help of clotting factors that get activated and from the intrinsic and extrinsic pathways of the clotting cascade, where you have all these different factors like factor 10 and factor 8 and factor 9, all of those get activated to essentially form thrombin and then fibrin, and that creates this very, sort of mesh network. But the mesh occurs, the red cells and platelets get sort of stuck in this fibrin mesh network, and that is really where the clot formation occurs. So again, this is just the exact same process, just looking at it from a different perspective. So going back to your pharmacology, drugs work either to stop clots from forming, thin the blood, and prevent coagulation, or they break down a clot that's already been formed. So you have to kind of think about all the different drugs that are out there. Platelet aggregation occurs when platelets become activated. So on the outside of the platelet are these glycoprotein 2B and 3A receptors. So when they connect to another platelet with the same receptor, they create a fibrinogen bridge. So these receptors need to get activated. So thromboxane and platelet activation factor, those sort of get, or what creates the initial plug and makes the plug more stable. So again, you can see already how aspirin works. Aspirin stops the cyclooxygenase pathway. You can have blockade of the receptors through the P2Y receptors. So you have like clopidogrel, which is Plavix. You can also actually stop the coagulation cascade as well. So that includes things like heparin, enoxaparin, dabigatran, rivaroxaban, apixaban, all work on stopping the clotting cascade from happening. Warfarin, also a blood thinner that you're very familiar with, works on prothrombin. So that's really a vitamin K antagonist. But irregardless, all of the blood thinners actually thin the blood versus antiplatelets, which work directly on some process for the platelet. Very important that you do look at your total CBC or look at your actual complete blood count. This is really just a basic, every hospital lab, every place you work is going to have slightly different variation on what they consider to be normal, depending on how your lab is calibrated. But in general, you have white count normally between 4 and 10,000. You have a red cell count between 4.2 and 5.9 million. Your H&H, those are for a male 14 to 18 and 40 to 54, and of course for a female is usually a little bit less, 12 to 16 and 37 to 47. And then you look at your MCV, which is your that's where your differential comes from, where you have your size of the plate of the red blood cell, you have the weight of the red blood cell, and the amount of hemoglobin that's actually inside the red blood cell. The MCV measures the size, the MCH measures the weight of the erythrocyte, and this can help you differentiate between the type of anemia that your patient has. You also would look at your platelet count, and then you would look at your white blood cell count differential, which is, of course, all of the different lymphocytes and granulocytes that make up the total white blood cell count. So when you're talking about anemia, there are so many reasons to have anemia. And if you recall, you can have anemia because of, for example, decreased hematopoiesis. This is really where you have consequence of just the bone marrow failing to produce erythrocytes. You will see this in nutritional deficits such as iron deficiency, or you'll see this in chronic disease such as cancer or renal failure. Again, renal failure, prime culprit for chronic anemia simply because there's loss of erythropoietin. So there's no erythropoietin to stimulate the red blood cells from being made from the bone marrow. You can have abnormal hematopoiesis where the erythrocytes that are produced are just abnormally shaped or abnormally sized. They're either too big or they're too small. So you can have, this is where you might think of your folate deficiency. Anemia. You might also consider the loss of iron as well. That fits into the abnormal hematopoiesis category. You can simply have increased erythrocyte destruction, where your red cells are normal looking, but they're destroyed or hemolyzed. So you see this in thalassemia. You can see this in sickle cell anemia as well. If they're destroyed, you can have, you see this in hemolytic anemia, secondary to like medications that may cause that. And of course, you can certainly just have simply blood loss. This can be acute or chronic. Acute blood loss, things like, major trauma, injuries, or surgeries. But more common is a chronic blood loss due to things like bleeding GI ulcers or lower GI bleeds. And those can sometimes go undetected in your patient. So what happens when you have a loss of hemoglobin? Well, your body has to compensate for that. And in an acute blood loss, you really don't have time to compensate. So when you don't have time to compensate, you're going to see signs of hypovolemic shock in your patient pretty quickly. But this really represents what happens in chronic blood loss. So if you think about mild anemia is really a hemoglobin between 10 and 14. Moderate hemoglobin is between 6 and 10. Moderate anemia is a hemoglobin roughly 6 to 10, and a severe anemia is generally a hemoglobin less than 6. So in a chronic blood loss, you have time to compensate. This is why you see pallor in patients, and patients are fatigued, and they have exertional dyspnea, and they're very cold, because there's loss of oxygen to the tissue, so the patients really do get short of breath. But in any case, you have this oxygen carrying capacity that reduces, so you have hypoxemia. And when you have tissue hypoxia, what you see is all of the assessment findings or all of the signs and symptoms in your patient. For example, because you have tissue hypoxia, you're probably going to have some ischemic changes. So patients will sometimes report claudication. Their muscles will hurt because they aren't getting oxygen to the muscles that need it. They become very fatigued. They start to have respiratory issues, so they feel very short of breath. They have exertional dyspnea. When your body is hypoxic initially, the first compensatory mechanism that kicks in is increased in respiratory rate and depth. So you'll have patients will be tachypnic because that is just simply trying to provide more oxygen to the patient. You start to then have more compensatory mechanisms where you are starting to have a cardiovascular response. You will see tachycardia in your patients because what happens is the heart has an increased demand. As the body's becoming more ischemic, the heart has to start compensating for potentially putting out more blood flow to the tissue. You're not actually adding oxygen, but the heart doesn't know that. So it works a lot harder. There's more oxygen demand, so the patients can start to have chest pain. That does stimulate the kidney to release erythropoietin if the kidney is functioning properly. So you should see an increase in red blood cells from that. However, it doesn't always happen because there may be some like abnormal erythropoiesis happening. But in regards to the cardiovascular system, what you wind up with is an increase in systemic vascular resistance because the kidney is trying to, that stimulates the renal system for an increase in the renin-angiotensin-aldosterone system. You have a release of aldosterone, which means that you're going to try to retain more sodium and water. The body starts to clamp down a little because of this, and you get this very hyperdynamic state. So that it's actually compensatory, where the body's trying to add more water or more volume or more flow to the kidney simply because there's not enough oxygen there to start with. And you will see patients with can also have a high output cardiac failure and a cardiac. You can have cardiac murmurs from that. One of the keys to recognizing this, though, is generally when we have patients who we think are going into some kind of shock, like they're tachycardic, we want to just give them fluid. But in actuality, fluid will make this worse because this patient's hyperdynamic state is what's keeping them from decompensating. So if we take that away initially, we can actually make it worse. So it's one of those things where this patient at this point actually needs blood more than fluid. So be mindful of that when you're starting to have orders to give your patients large amounts of fluids. The different types of anemias that you have, of course, iron deficiency is a microcytic hypochromic anemia. Iron deficiency is going to be the most common. You have very loss of iron for hemoglobin production, so you wind up with very pale, small-looking erythrocytes. You see this in times of decreased iron intake, in chronic GI loss, in GI bleeding. Classic signs, though, are going to be glossitis and cholinicia. Glossitis is, of course, your very shiny tongue. And cholinicia is the change that occurs in the end of the fingernails, and it's simply because it's really a loss of oxygen to the tissues. Treatment is really going to be iron supplementation. We can do iron orally, or we can actually give it as an IV infusion. And the other microcytic hypochromic anemia you may see is a thalassemia, which is really just impaired synthesis of alpha and beta hemoglobin. Congenital defects occur because of this abnormal hemoglobin synthesis. And so what you see are all your classic symptoms of anemia, except that when you do an iron panel, you're going to see normal iron stores, because this is not an iron deficiency. This is an actual change in the way that alpha and beta hemoglobin are made. Your macrocytic anemias are your very large, so you see a large MCV and a large MCH. So this is these are your large, abnormally sized red blood cells, erythrocytes. So there's two. Pernicious anemia is really lack of vitamin B12, and this leads to what's called a megaloblastic anemia. Might be another term you hear. So you have impaired DNA synthesis and red blood cell maturation, because vitamin B12 and folate are really needed for the production of the erythrocyte and sort of the DNA and RNA of the erythrocyte. So the erythrocyte itself, the red blood cell, is very large, but its cell membrane is very fragile and can easily be destroyed because of the loss of the B12 and the folate. So the hemoglobin content looks normal, but the cell itself is very large. So you can have a lack of vitamin B12. You see this in patients with chronic gastritis. You see this in patients with malabsorption syndrome, from all kinds of GI problems. Can also be genetic or immune related because there's a deficiency in intrinsic factor. Intrinsic factor, of course, is needed. That's made by the parietal cells in the gut, and that's needed to transport vitamin B12 across the cell membrane. It's a very large vitamin. So you can see a pernicious anemia in like a chronic gastritis or in a GERD situation. And the treatment really is to replace the vitamins B12, folate. Now, folate deficiency is frequently seen in, again, malabsorption syndromes and malnourished patients, but also in chronic alcohol users. You simply replace the B12 and folate that are not being absorbed for the patient. Your normocytic, normochromic anemia are really just normal-looking cells. There's just less of them. There's a whole slew of anemias really in this realm. You can have this simply bone marrow failure, so aplastic anemia, very rare. Only about 4 in a million people get actual aplastic anemia, but this is really creates a picture of pancytopenia, right? You have bone marrow failure due to like congenital problems. You can also have them acquired due to infections, chemical agents such as arsenic or pesticides. Medication side effects can cause this as well. You see it sometimes in heavy doses of anti-seizure medications like Tegretol and Dilantin. But your hemolytic anemia is really destruction of erythrocytes. That's simply the red blood cells are being destroyed at a rate that exceeds the production of them. So this, again, can be a defect in the red blood cell itself. So you can see this in times of like sickle cell anemia. So in patients with sickle cell anemia, when they're in crisis, those sickled cells wind up being hemolyzed because they get destroyed. They can't get through the cell wall. You can see this in exposures to toxins. You can see this in ABO incompatibility. When you maybe get the wrong blood, all of a sudden you're going to have destruction of the erythrocytes because of the incompatibility of the blood and because of the immune response. You can see hemolytic anemia in times of mechanical injuries. So, for example, those patients with mechanical heart valves, prosthetic heart valves that are mechanical, that can actually destroy the opening and closing of the valve, actually destroys the red cell itself. So lots of reasons to have a hemolytic anemia. You can also have certainly a hemorrhage where you have an acute blood loss. You can have also anemia of chronic disease. So after we've sort of ruled out all of the other reasons to have anemia, you kind of see anemia of chronic disease when you have just simply a decreased production of erythropoietin or a decreased production of erythrocytes. So most often related to chronic illness, chronic renal failure, or any kind of malignancy. Polycythemia is the opposite. That is actually increased red blood cells in the bloodstream, and so this causes a hyperviscosity and a hypervolemic state. Very unusual. It's not something you see. It's usually something inherited. Symptoms are, of course, gonna come from the high viscosity of the blood. So think about, I don't know, almost being super dehydrated, but you can have, because you have a high red cell count, you can have blood clots, and a lot of times you get thrombus formation. So patients with polycythemia do have thrombocytosis frequently, where they're getting large blood clots. So you can have like paresthesias and neuropathies simply because there's just tons of blood clots in the microvascular circulation. And one of the ways to actually do this is to simply reduce blood volume. So we do give the patient IV fluids to reduce the viscosity, but we actually have to treat them with phlebotomy and actually just simply reduce the amount of red cells they actually have. Now, in order to stop the body from overproducing, we usually use myelosuppressive agents, so almost like a chemo type agent long term. So you might see this in steroids, patients on steroids. You might see this in other immunosuppressive agents to try to just basically stop the bone marrow from overproducing red cells. And thrombocytopenia, of course, is your platelet reduction in platelet count. This is usually marked by a platelet count less than 150,000, and there are lots of reasons to have thrombocytopenia. You can have an inherited disorder such as, Wiskott-Aldrich syndrome, which is an X chromosome mutation. But the majority are going to be acquired, and either they're acquired through immune process or non-immune process. So in the immune process, you have like an idiopathic thrombocytopenia purpura, which is essentially where you've had an immune response, you've had like an infection such as mononucleosis caused by the Epstein-Barr virus, and you have basically this immune response that occurs, which decreases the production of thrombocytes. You can also have liver disease, such as liver failure, which stops the production of thrombopoietin, which then stops the bone marrow from making thrombocytes. And you also have non-immune states like drugs that can cause it. It's basically just an increase in consumption of the thrombocytes. They're just basically the platelets are being eaten up, usually through like medications like thiazide diuretics, vancomycin, heparin. Those can all cause thrombocytopenia. You can have thrombocytopenia from warfarin or aspirin as well. You have DIC, which is a process that occurs after sepsis many times, or a significant blood loss, and or you can just also have turbulent blood flow where platelets are simply being destroyed. Signs and symptoms in your patient, the most common, of course, is going to be petechiae or microvascular hemorrhages. You're going to see a lot of bruising, a lot of ecchymosis. This over here is actually extreme, where this occurs with HIT, which is heparin-induced thrombocytopenia, where the patient has increased consumption of platelets. They wind up with bleeding, but they also wind up with blood clots at the same time. And so this is what these microvascular changes would look like. Impaired hemostasis comes simply from dietary vitamin K deficiency, where patients who are at risk for bleeding, vitamin K is a fat-soluble vitamin. It's needed for the synthesis of prothrombin, procoagulation factors like 2, 9, and 10, and anticoagulation factors protein C and protein S. So when you have a reduction in vitamin K, then you have a reduction in the ability to make blood clots, so you have impaired hemostasis. So bleeding is really the biggest concern. You can also have liver disease where you have coagulant factors that are made by the liver cells themselves get depleted, and that will affect the clotting cascade. And so patients with liver disease frequently have bleeding tendencies. Hemophilia is a X-linked and von Willebrand's. Those are X-linked recessive disorders. You essentially have a defective or deficient coagulation factors, usually 8 and or 9. So really this occurs when you have, because you have a loss of these coagulation factors because they aren't made readily. When you have bleeding, you can't stop the bleeding, so the clinical signs are really related to excessive bleeding, both internally and externally. So really the treatment when you have hemophilia is prevention of bleeding, but if you do get injured, we have to stop the bleeding. And in order to do that, we usually have to give the patient replacement of both factor 8 and factor 9, and also we use DDAVP, which is essentially something that can stop bleeding. We also have to replace the patient's blood products, their packed red blood cells and FFP, and that will also help give them clotting and coagulation factors. And finally, we have DIC. DIC is disseminated intravascular coagulation. It is really marked by widespread coagulation, secondary to the formation of fibrin clots. What happens is the body creates so much fibrin clots that you have blockage of blood flow to major organs. And then because there's so many clots, and this is usually in small vessels and in the microvascular circulation, this causes multi-system organ failure. So essentially you have this widespread ongoing clotting, and that just uses up and depletes your clotting factors very quickly. So the body isn't able to replace those clotting factors, so you have impaired clotting. But then because there's already so many clots being made, you have so much fibrinolysis occurring. So what happens is you wind up with a clinical picture where patients are clotting and bleeding at the same time. Very difficult to treat, usually many times fatal in the patient. Number one reason to have DIC is actually sepsis, gram-negative sepsis actually, and it's simply because there's so many endotoxins that are released that this is just widespread systemic inflammation in all of the microvascular circulation. You also see this as a pregnancy-related complication as well. When you have placental abruption or eclampsia, where you've had just an extreme blood loss from the pregnancy itself, this is a complication that can happen from that as well.